All right, so welcome again. We're working out some of our technical issues early on to get that all solved. Welcome to our webinar. The title is Zika Frontline Research and Preliminary Findings. My name is Kristen Hedges. I'm the co-chair of the Society of Medical Anthropology's Zika TIG group. This is actually our second webinar series. The first one was offered back in April, and that first one really was just giving an overview of Zika, what it was, and the public health emergency. Today, I'm thrilled to be back because we have a great lineup of speakers who's going to talk to us about some of the preliminary findings that they have had in the field. So I am just going to, with that, oh boy, hang on one second. Sorry about that. I'm going to give just a quick overview of the speakers that we have. After me, I'm going to pass it off to Juliette Bedford from Anthropologica, and she's going to give us an overview of Zika, and then from there we're going to hear from Christine Ricardo, who's going to talk about Zika in Brazil and gender and reproductive health practices and decision making. After that, we will move on to Lucia Guerra-Reyes, who is in Peru and will be speaking on gender hierarchy decision making around pregnancy. And then we will also have Sheer Lehrman speak on Puerto Rico and the political economy. Lori Denyar-Willis was scheduled to be our last speaker, who was going to be talking about sub-Saharan African response. Unfortunately, she's actually in South Africa right now and doesn't have enough internet connection to be a presenter. Hopefully she can join us. She's going to try to join us and listen in, and possibly maybe can join us in the chat window, but we are not going to be able to hear from her today. And we have left a lot of time at the end for question and answers and discussion time that we're hoping to be able to have some interactive time at the end. So at this point, I'm going to go ahead and pass the presenter role over to Juliette.
Hi, Kristen, can you hear me okay? Great. Thanks, Amy. Perfect. Okay, that's good confirmation. Thanks all. So yes, just to follow on from Kristen's invitation to speak today, it's really nice to be able to connect with colleagues on the second webinar that we've done on Zika. I just want to start by giving a brief overview of where we are, bringing people up to speed on the current situation. So Zika was declared a public health emergency of international concern back in February last year, the 1st of February 2016, and it was degraded from a public health emergency on the 18th of November, so for the majority of last year. What's happened now is that many agencies and organisations, in terms of the response itself, is shifting over to much more of a care and support programming role. So looking at ongoing programming to do with care and support to children affected by microcephaly and other neurological congenital syndromes, and also their families. So bringing in much more to play around ongoing livelihood, sustainabilities, and looking more again at the health system strengthening piece as well. Up till now, we've had 70 countries and territories who have reported evidence of mosquito-borne Zika virus transmission since 2015, and 7 of those have reported possible endemic transmission or evidence of local mosquito-borne infections in 2016 and into the early part of this year. 13 countries have reported evidence of person-to-person transmission of Zika virus, and 29 have reported microcephaly and other central nervous system malformations potentially associated with Zika virus infection, also suggestive of other congenital infections. 21 of those 70 countries have reported an increased incidence of Guillain-Barré syndrome and or laboratory confirmation of a Zika virus infection amongst GBS cases. So having had a period where there was actually no new countries or territories reporting cases, in the last week, Wednesday the 11th of January, Angola reported 2 Zika cases. So I just wanted to list out here the countries per region, and these are applicable to the WHO regions, where we've had Zika cases or there is currently ongoing Zika transmission. I won't go through all of these now, but just useful to see an overview. And I just like to bring to colleagues' attention who may not be aware of it, every 2 weeks, it was every week during the public health emergency, but now every 2 weeks, the WHO released the latest SITREPs, which provide the most up-to-date information and data that we have globally on the emerging cases of Zika. They're published every Thursday, so the next one will be out tomorrow, and this is the web link. So these are openly available on the website for you all to refer to. So I just wanted to quickly give you an overview of some of the research activities that have happened over the course of the last year, from about this time last year. So really there's been a spectrum of research, from rapid research on one side, and really that's good enough data that can be quickly operationalized. So CAP surveys, house-to-house surveys, and really moving from that on one side all the way towards longer term, more systematic research. And I'll speak a little bit about those different types of research over the course of the next few minutes. So one thing I just wanted to bring to colleagues' attentions, and this we also highlighted on the first webinar, was around the CAP resource pack that we put together with the WHO, and that has now been rolled out by many different partners and agencies over the course of the last year. Again, this is open source and is available on the web link there, and has been translated into several different languages. So this survey tool was put together as a direct ask from PAHO, the Pan American Health Organization, who was wanting a tool that people could really use as a template, whether they're Ministry of Health, government, civil society organizations, or other partners and agencies, to be able to rapidly assess knowledge, attitudes and practices to do with Zika and to vector control more broadly, and also looking at some aspects of community engagement. What we have tried to be doing as well is to really map some of the social science and operational research that's been happening across the response. So if you click on this link, then it will take you to an interactive map that the WHO put together, which is really trying to keep track of different partner agencies who are doing research, initially just across the Americas region, but we're now looking at expanding that to document research that's happening in other areas as well. At the moment, the research that's noted there is actually research that is only coming from the UN agencies and other partners and funding bodies. But what we're looking at doing is seeing if we can also document there other research, more academic-based research, and working with independent researchers to make sure that that information is openly available as well. So these are some of the key partners that we've been working on in the response who have been engaged with operational research. And it's great to have several colleagues from these partners on the line, including World Vision, from Interviewees, from USAID as well. So I'm grateful for you to join today and have the opportunity to hear what some of our colleagues who are recently returned from the field, some of their preliminary findings. And this leads me on to the last few points that I just want to make. What we have been able to do with this temporary interest group around Zika is really look at crowdsourcing information. So using the extensive research experience that's already there and long research engagement in the region and now more globally, and really looking at how we can mesh that with some of the emerging issues that are coming from the ground. So we've set up a network of anthropologists and other social scientists who have been very generous with their time and expertise to feed in ideas and perceptions, experiences from the ground as to a lot of the community perceptions, not only of Zika and the response, but also looking forward to do with some of the longer term issues that will be arising. And again, this brings me back to the care and support programs that are now being put in place. And these are the focal countries where we've had visibility of ongoing research. And again, this is research from the rapid research and the good enough research operationalizer, all the way through to longer, more systemic research projects as well. I may have missed countries off, and if that's the case and you know of other research projects, then please do let me know, and we'll make sure to keep this as up to date as we can. But as you can see from this slide, there is a lot of research being rolled out globally now. And that leads me on to today's presentations. It's me great pleasure to introduce the 4 speakers. All of these colleagues have been very engaged with the temporary interest group, with the Zika response more broadly, and have been very patient with me, sending them lots of questions over the course of the last year to really try and learn from their experiences on the ground. So it's really wonderful to be able to introduce them now and give the opportunity for them to present some of their preliminary findings and data from the field. So I will, without further ado, pass straight over to Christine, and we'll be hearing from her about her work on gender and reproductive health practices and decision making in Brazil.
Hi, everyone. This is Christine. I hope everyone can see my screen. Okay. So I'm a clinical fellow with the GHJP, the Global Health Justice Partnership. We're a joint initiative between Yale Law School and Yale School of Public Health. We do teaching, research, and policy advocacy on global health justice issues. And I am based in New Haven, Connecticut, but I am incredibly fortunate to be part of a team of incredible researchers, all of whom are actually based in Rio. So I just want to give a brief background as to why we started this study. Last year, as part of a practicum project with students, law students and public health students, we wrote a statement for a pending petition to the Brazilian Supreme Court in a case that is demanding services and supports for affected women and families. And as part of the statement, we did an analysis of the guidelines the Ministry of Health had issued for reproductive health care providers. We identified shortcomings and provided some recommendations grounded in public health and human rights frameworks. It was very much a desk-based analysis, and so the idea for this study really grew from that process. We wanted to develop a more informed, more nuanced understanding of sexual and reproductive decision-making and practices, and how influencing those. I'm just going to see if I can mute. Okay, sorry about that. So Rio, we chose to focus our research in Rio for several reasons. At the time, there was a lot of focus in the Northeast, and correctly so when we looked at the epidemiology, but we also wanted to expand the conversation. And Rio was a particularly interesting location when we looked beyond the Northeast because it had a high caseload. And actually, currently, Rio has one of the highest incidence of Zika infection among pregnant women. And again, as many of you might remember, because of the Olympics, it was also very much in the spotlight of international discussions and concerns around implications. So just a little bit of geography, Northeast, the concentration of the epidemic, specifically the association with microcephaly, the microcephaly cases have been concentrated here in the Northeast, and we were here in the Southeast in Rio. So we are ultimately focused on thinking about recommendations for health services. So that interface is very important for us. In addition to understanding the influence of Zika on reproductive health decision-making and behaviors, we also wanted to get a sense of what took people to health services for reproductive health concerns, their perceptions and opinions of those services, and of course, if and how Zika had been playing a role in their interactions with providers and the services they sought or received. Initially, our recruitment criteria were very broad. Essentially, we were looking to speak with adults who had visited a healthcare facility at least once for reproductive health concern since October 2015, when Brazil first reported a suspected association between Zika and microcephaly. We then did a quick pilot in July and realized that unless pregnancy was at that moment a salient part of individuals' lives or thinking, Zika really was not a very immediate concern, and we wouldn't have as much substance to explore. So we decided to narrow our criteria to individuals who were recently or currently pregnant at the time of the interview, or recently or currently planning to get pregnant. We did a combination of convenience and snowball sampling to identify potential participants, working with local community contacts. And we have been interviewing individuals from both low-income and middle-income communities in Rio. So far, we've interviewed 15 individuals, including amongst those 3 couples. We've interviewed 10 women from low-income and middle-income neighborhoods and 5 men. At this point, all the men are from low-income. Of the women, 7 were currently or recently pregnant at the time of the interview, and of the men, 4 had partners who were currently or recently pregnant, and 1 was planning, he and his partner were planning to get pregnant. And it's important to note that most of these interviews, 13 of the 15 interviews, actually took place in winter time in Brazil, so between July and September. And most of the pregnant women that we spoke with or spoke about via their partners had been pregnant during that first summer of the outbreak, so the initial months of the outbreak. We did have done some interviews more recently now in December, but even those individuals were pregnant during the initial outbreak. So because there's not a lot of time, I'm really just going to do a very quick sample of things that we heard in these interviews. It's not so much as an analysis as highlights of things that really impressed us and that we are hoping to tease out in our analysis. So at the onset of our interviews, we really wanted to be thinking throughout much more broadly about reproductive health, behavior, practices, norms. And so we started our interviews by asking some foundational questions about health-seeking behaviors and perceptions, opinions about health services and providers. As many of you might know, Brazil has a public health system, the Sistema Único de Saúde, or SUS, and they also have a robust private healthcare sector. Nationally, approximately 30% of individuals have private health insurance. Within the study, 8 of the interviewees had private health insurance. For the others, though, for the other 7 individuals we spoke with, and also for those who had private health insurance at that point of the interview, there really was very much a narrative of patchwork utilization, where when individuals didn't have private insurance, there was mostly reliance on SUS, but for certain services, they might actually prefer to go without or to pay out of pocket because of concerns, frustrations with the public health system. In terms of frequency or motives for seeking care, as we see in most other settings, women that we spoke with seek out preventative health services much more regularly than men. For women, the most common reason for seeking services is for gynecological preventive care. And actually, for most of the women, that was essentially the only time they would seek out health services other than being sick or for emergencies. For the men we spoke with, only in emergencies, they would seek out healthcare services. Our one exception was actually our PE teacher, our physical education teacher. And actually, it's worth noting here that 3 of the same men who said that they only sought out healthcare services in emergencies were actually regularly accompanying or had regularly accompanied their partners, their pregnant partners, to prenatal appointments, and actually very eagerly so had gone to those appointments. So which of course leads us to wanting to think more about prenatal care or fatherhood-focused services as an entry point for thinking about men's health care and information. There was also discussion about some barriers to health seeking. Both men and women spoke of a culture of machismo in which boys and men were not socialized in the habit of caring for their health. So one man saying that men don't go to health services because of perception that care is not something that they need. A woman saying that it's still very difficult to see men when you go to the doctor. You see mostly elderly people, women and pregnant women, and speaking about her brother who had apparently had some kind of sexual transmitted infection and essentially didn't know what to do, where to go, and came to her for advice. And she closes here by saying that women have a habit of checkups. Of course, not all women go, but if something happens, at least they know to go to the gynecologist. Men can be a bit lost. They don't have this habit. They don't develop this habit of caring for their bodies. However, perhaps the most noted barrier to care for both women and men was an institutional one, essentially the shortcomings in the public health care system, which you can say is a socioeconomic barrier also in a way, because income and class very much dictated how dependent individuals were on the system. And so we had interviewees who spoke about the frustrations with the system, including long waits, understaffing, and unequal quality of services across locations. The second quote, for example, is a man who would actually travel by bus an hour and a half within the city of Rio, but to another neighborhood because the public health clinic there had a somewhat better quality of care for him. Many also spoke about how their frustrations with the public health system influenced their frequency and motives for seeking care. So one woman saying that now that she had health insurance, she generally goes once a year. But when she didn't have health insurance, she would go without a doctor because SUS is really complicated. I'm only able to go when I have an emergency. Even at the clinic, you have to be sick to be seen. And several also spoke of the preference to pay out of pocket to ensure more timely care. We have a woman who said, I go to a private gynecologist because I find it easier. The exam results come quicker. For everything else, I go to the public health system. So these quotes really capture a lot of what I meant by when I said the patchwork utilization. So folks who are dependent on the public health care system really opting to use certain services, opting out of certain services, or to pay out of pocket. So we also spent a good chunk of the interviews asking questions about the prevention of pregnancies, from gender norms around responsibility and communication to actual practices and methods. Most of the men and women spoke of a disconnect between what they believe the division of responsibility and what between men and women should be and what actually happens in practice. The second quote here, a young woman saying, normally it's the woman who has to manage. In my other relationships, it was always like that for me. If I didn't protect myself, there would be another 10 kids in the city. And the final quote, a man saying, the responsibility is on both, but that's not how it happens. There's really no way around it. We live in a patriarchal and machista society. So communication between partners, although some spoke of openly communicating with their respective partners about pregnancy prevention and contraception, there was a general recognition that this was not necessarily representative of most couples in their cohort and community, across both casual and fixed relationships. So one woman saying, in terms of using condoms, I know lots of girls who are not able to have that space, not even to ask for a condom. Because if her boyfriend doesn't want to use it, she ends up having sex without a condom in order to not get into a discussion. And then these other two quotes here are men who were in long-term relationships saying that they actually didn't remember ever having any explicit conversations with their partners about birth control, but at the same time, they're not necessarily being an intention to get pregnant. So in terms of methods, there was no strong opinion regarding a method that was particularly ideal or good. Most commonly used were the pill and the condom, although there were very negative perceptions regarding both. Around the oral contraception or the pill for women, there were many concerns about the side effects, the damage to women's health, and also discussion of the costs as a barrier. In terms of condoms, in addition to a very strong symbolic association between non-use and trust, there was also lots of references about condoms being bothersome or about causing allergies. This quote here from a woman, I think, captures very nicely the idea of the symbolic association around the use of the condom. She says that in the beginning of the relationship, we used condoms because we were still getting to know each other. It's very common. You act on the basis of trust. I know that's not recommended because other things can happen along the way, but in the end, it's a matter of trust. And she talks about in her relationship, about a year and a half into the relationship, she decided to stop using condoms because it's that question of care. I believe he is careful with me like I am with him. So the majority of the pregnancies amongst the cohort were unplanned. And as we saw in an earlier slide about communication between partners, for many of the couples, there were inconsistencies between what their reported pregnancy intentions were and what their actual birth control use was. So these first two quotes here are from women who had unplanned pregnancies, were in long-term relationships, but were not using any method. So for those individuals who had been recently pregnant or were currently pregnant, we also spoke about their access to and experiences with health services relating to the pregnancy. And again, as we saw with the general use of the healthcare system, we saw similar barriers to accessing prenatal pregnancy-related care specifically. Interviewees spoke of seeking out private services for ultrasounds during their pregnancy, both to avoid long waits, but also because they wanted more ultrasounds than what was provided through the public health system. So this first quote is a woman saying that it's very difficult to get an ultrasound via SUS, via the public health system. You're only entitled to 2 during the entire pregnancy, and if you don't have the money, you don't do more than that. And explaining that there was one towards the end of the pregnancy, the morphology scan, that is not covered and that you have to pay out of pocket. And the cheapest place that she had found was 180 reais. And she reflects a little bit about what that would mean for many women, for whom younger women, poor women who might not be able to pay out of pocket, pay that amount out of pocket. So as I mentioned, there are 3 of the men that we spoke with were or had been accompanying their partners regularly in prenatal appointments and ultrasound appointments. However, the general consensus was that this is not typical. The second quote here is a woman speaking about how she was happy that her husband was participating, particularly because it was not something that was common, and speaks about having friends, got pregnant, had kids, and that it was very rare for the fathers, husbands, companions to go to prenatal. And speaking of, how when she usually goes, her partner will be with her, her family will be with her, but she'll usually see only 1 or 2 other fathers there. And in this last quote, there was a woman who mentioned her partner going to the first ultrasound, specifically because he was worried about Zika. So again, this is something else that really caught our attention in terms of, you have the general health service access question about engaging men through prenatal care, but then also opportunities for Zika itself and the concerns around Zika as another way to engage men in reproductive health and prenatal services. So of course, then we spent much of the interview delving specifically into knowledge, perceptions around Zika, prevention behaviors, etc. And when we did the bulk of the interviews in July, August, surprisingly, there were still many doubts around the association with microcephaly. And this was, again, this was several months after WHO had already declared a strong scientific consensus. But there was still really a substantial amount of skepticism about whether or not there was that association. This first quote is a woman saying that because the concentration of cases was in the Northeast, they thought that there might be some other factor involved. And in all of the, interestingly, however, although there was a lot of skepticism, a lot of doubt, everyone who was pregnant, who had recently been pregnant, was definitely erring on the side of caution in terms of taking certain measures to prevent against infection of Zika. We did ask about sexual transmission, and there was very patchy knowledge about sexual transmission. One man whose partner was 7 months pregnant at the time said that he didn't know about sexual transmission. He knew that there was something about kissing on the mouth, but otherwise he wasn't very certain and didn't know whether or not that was Zika or chikungunya. A woman who was actually trying to get pregnant at the time said she had heard something but hadn't really sought out more information or spoke to her partner about it. And there were many individuals who talked about this reference to kissing, and there was some of you might remember, but last year around Carnival, so which would have been around February or March in Brazil, was when there were initial studies showing some the presence of the virus in Zika. So right around Carnival, there was kind of a media blast around the possible risk of transmission through kissing. And that had definitely kind of stuck in people's minds. And so when we asked about sexual transmission, there was very much an association with, well, something about kissing, but not really a lot of kind of detailed information about transmission itself. So in terms of reactions to pregnancy, to being pregnant in the time of Zika, there really was a range. And I think I chose these 3 quotes because I think they show some of the range of reactions. The first is a woman who talks about how she doesn't think people were really limiting themselves. She had a friend who was pregnant. She took certain precautions, put on repellent, changed a few habits, but it wasn't really an issue of, oh, I can't have kids now. And there was, definitely a number of folks that we spoke with, speaking both of themselves and others that they knew, that it was a matter of taking precautions, but there wasn't really, more concern than that. The second quote is a man talking about as he was very worried, and in fact, if he could have, he would have preferred to delay. And the final quote is a woman who had an unplanned pregnancy, and the timing coincided exactly with the kind of blast around Zika, and she talks about even having contemplated abortion. I am looking at time, and so I'm going to wrap up very quickly here. We talked about prevention, lots of use of repellent. However, folks talked about, they were encouraged from health service providers to use repellent, but there wasn't adequate guidance about particular brands that they should be using, and there was not consistent use among male partners. So even for individuals who knew about sexual transmission, there was not consistent use of repellents in terms of their partners. Sexual transmission, again, little knowledge, also translate into very limited measures. People not really a concern about using condom, about safe sex in the context of pregnancy and Zika. However, interestingly, there was one couple who had never used a condom at all in their entire 7-year relationship, but started using condoms specifically during pregnancy because of his concern around Zika. So there are other things that came up, lots of perceptions, criticisms of the media coverage of Zika, people complaining about the psychological terrorism, how it was unreliable, and also we have a good chunk of material where we ask people their perceptions and criticisms of actual and proposed government responses, and also something that we're hoping to explore more in the analysis. So with that, I am going to close. Thank you very much. I am going here. I'm going to pass the presenter role to, let me see.
Okay, thank you. Can everybody hear me? Thank you. Thank you so much, Christine. That was a wonderful presentation. I wish we had more time that we could explore it. Hopefully, if everybody can hold some questions. Are there a few questions we want to take right now, and then we will move on? We also are going to have time at the end that we're saving a big chunk of time for questions. But if there's a few questions right now for Christine, we can take those. And I've opened up, unmuted everyone for kind of a question period, or feel free to type in the chat window. If there's no questions right now, we'll go ahead and move on to Lucia's presentation and work on some questions. So Alfonso's asking if there's a report. Are you asking about a report for Christine's preliminary findings? Yes. Christine, is your team working on a report or a paper that these findings are going to be presented in?
Yes. We're hoping to have an article or short report out by June. And we're also collaborating with a group that's doing some research in the Northeast. And we're hoping to do a larger report that will have comparative analysis.
All right. Great. Thanks, Christine. We'll be looking forward to those.
For like 2 minutes, and then I have a brief.
Are there any other questions at the moment?
But I can do that anyway.
Okay, so Lisa says, thank you, Christine. Could you briefly mention some of the government response to Zika?
Sure. So what guidelines of the health service provider.
Could we ask people to mute again?
Okay, so people, I've muted, that way we can. Christine, why don't I pass the presenter role back to you, and then we can go ahead and mute everybody else for these questions. So keep typing your questions in the chat.
So hi everyone, just very briefly about the government response. There's been started our,
Christine, if you could mute everyone before continuing to answer, I think it would be clear. Perfect. Christine? Christine, are you still with us? Christine? I think we may have lost Christine. Is anybody able to hear me?
Hi, I'm back, sorry.
Okay, perfect. Okay. Great. All right, so Christine, I'll have you mute everyone before you continue with the answers of the questions.
Okay.
Perfect.
Great. Okay. So in terms of the government response, the Ministry of Health, we've been very much focused on the Ministry of Health guidelines for reproductive providers. What we're trying to get a sense of now is what has been the actual kind of rollout of those guidelines. What inspired the study were these guidelines the Ministry of Health rolled out. It's not being clear what the actual rollout has been at the level of healthcare providers. So the next month or so, we're going to be looking very specifically at training, sensitization that have been provided for healthcare service professionals. There has been a very actual comprehensive response in many ways, from the epidemiology, from addressing breeding grounds, to mosquito eradication, from the science, et cetera. So there has been a tremendous response across different sectors of the government. Unfortunately, as many of you know, there was a ongoing actual political crisis in Brazil that distracted a lot of the resources and a lot of the media attention and mobilization from this issue. There's currently, and again, I mentioned this, there's currently a case at the Supreme Court that we're expecting a decision very soon that is using constitutional claims to ensure that individuals affected by Zika have access to services. So from ensuring distribution of birth control methods and mosquito repellent through health services, all the way up to ensuring that families with children have access to social service benefits and health services. So a lot of things have been put on hold or kind of shuffled to the side because of the political crises, but there's been incredible advocacy in terms of trying to hold the government accountable moving forward. I'm gonna pass it back to you, Kristen.
All right, thank you so much, Christine. We are going, can everybody hear me now? Okay, so we are going to move on. Please, if you have other questions for Christine, just hold on to them, because we are saving some time at the end of all of our presenters to have some open discussion time that we'd love to get people's thoughts and have some further discussion at that time. So we're going to move on. I'm going to pass the presenter role to Lucia now, and she's going to be talking about gender hierarchy decisions in Peru.
Hello, everybody. Please let me know through chat if you're listening to me. Yes? Awesome. Let me put this in presentation. So I'm going to be talking about the gender and reproductive decisions under threat of Zika in Peru, and this is research that we conducted with NSF funding over the June and July period before the arrival of Zika in Peru, with collaboration with my colleague from the Universidad Peruana Cayetano Heredia, Ruti Guinness. There we are. The study had as an objective to explore the gender dynamics of reproductive decision making. We wanted to know if women and men in unions, so actually in unions currently, discuss, decide, negotiate, decide on the number of children, the use of contraception and condom use, with the underlying assumption that understanding the reproductive decision-making would be crucial in emergency and long-term Zika response. And we also wanted to know, before Zika began spreading in Peru, what was the level of knowledge of the reproductive implications on Zika and the risks, the perception of risk of the people there. Since Zika had not yet started in Peru, we actually chose Iquitos because it was very likely that that was going to be one of the places where it would begin, given that it is endemic for dengue and has a very high presence of the Aedes aegypti mosquito. So Iquitos itself, and if I go back once, you can see it's in the Amazon jungle. It's on the Amazon River, and it is a city that houses around 400,000 people. It is only reachable by river or air, and is the second largest city in the Amazon. The other one, I think, is Belém do Pará in Brazil. We centered within Iquitos in an area in conversations with the local regional Ministry of Health. We centered in an area called Moronacocha, which was chosen because the local regional health director and epidemiologist there had identified higher historical concentrations of the Aedes aegypti mosquito in that area. Therefore, it had also been an area where there had been dengue deaths from hemorrhagic dengue a couple of years prior. So the thinking was people would be more primed to be listening, thinking through Zika prevention, perhaps. Moronacocha is, as you can see, there's a picture on the left. It's a mixture of a settlement. It's actually on a port, in a lake that used to be used for fishing, but is now heavily contaminated. But it is still a port city that receives some of the materials from the further upstream in the Amazon. It has been settled by successive waves of migration from indigenous peoples who live upstream. The roads are not paved, and there is a mixture of houses that are palm wood, traditional wood, it is mostly a low-income area, but there are some middle-income houses sort of sprinkled through, and professionals that live there. Local men and women in that area, generally men are low-income, like I said. Generally men, I would say, at least 100% of our participants, no, not 100%, maybe 90% of our participants, men, actually drove mototaxis, and that was their livelihood. This is the preferred form of transportation, as you can see on the picture on the left, in Peru. And women in that area, when single, worked in small part-time jobs, but now that they are, that most of them, the ones that had children, stayed at home. Some have had small sort of ongoing cottage industries. They sort of sell stuff from their home, have little front room shops and things like that. While we were in Peru, the Zika public health response began. When we arrived in June, When we arrived in June, there was no active ongoing Zika cases. And then at around June, in the month of June, they began, but not in the city of Iquitos, but in an outlying area and also in Cajamarca. So the public health response initially was basically vector control. So here we see some pictures. There was a very catchy tune PSA that was playing in the health center, and that was sort of a show that went around town in different health centers that said, the mosquitoes that transmit dengue and chikungunya also transmit Zika. Don't let the mosquito in your house. So everything was centered around vector control. There's some fumigating people there, etc. Later events while we were there in July involved visits with pregnant women, specifically from health providers, community information events in schools and health centers. By the time we left, there were already 3. By the time we left Iquitos in July, there were already 3 autochthonous cases of Zika and of local transmission. So I'm going to talk very briefly about our reproductive decision. We have a lot of information on different things. I just want to mention that the patchwork of a health system that Christine was mentioning in Brazil is mimicked almost verbatim for Peru. We have a public health system, but there's also private possibilities if you have money. So your access to healthcare is very much dictated by your socioeconomic situation. And in this case, reproductive decision making and the extent to which women participate actively in discussing, etc., reproductive decisions also is very much restricted by the socioeconomic status. So we centered on the Moronacocha Healthcare Network. And so as part of the Moronacocha Healthcare Network, we interviewed people at the main health center, healthcare providers at the main health center and at the peripheral health centers that reported to this main health center. With help from some local contacts, we were able to interview 28 women and 21 men who were currently in unions. We had 3 people deployed that were doing this for nonstop almost for all of the month of July. And we also conducted 3 focus groups, 2 with men and 1 with women. We conducted 2 male focus groups because it turned out that in our first focus group, most of the men, there was a small focus group, were actually gay, so not really thinking about reproductive decision making at the time. So we found that really there was some things that people who work in the Amazon and in Iquitos know. There's a very early sexual initiation, so 15, 16 years old. Interestingly, and not interestingly because it's all been said before, probably, men initiate with public women, prostitutes, or women who they view as public because they find them, they're sort of hookups and one-night stands, and women with boyfriends. The issue of early sexual initiation is important because when it comes to discussing healthcare, reproductive decisions and contraceptive use pre-union, before they're in unions, we found that women wanted to or needed to, in a sense, to perform purity. Before unions, there was no contraception. The only non-contraception method that they used was withdrawal. But men would use condoms with women who were more public. So with prostitutes, with women that they picked up at parties and others. but they would not use condoms with what they would consider their main girl. And there was mostly an age difference when establishing these unions. So we asked primarily, how did you establish your union? How was it when you first started going out, etc. And we found that there was a very large age difference. So men were generally 3 or 4 years older than their partners. And so the women talked about this knowing about contraceptives, especially younger women, but not wanting to say anything because asking for use of a condom was related to being more public. So knowing too much would be a hindrance in your relationship with this man. So men talked about liking or wanting to be with the partners that they were because they were quiet, because they were from their house, because they were not these more public women who like to be out there and go to parties and drink. And this has implications because the union, as we found out, basically occurs on discovery of an unplanned pregnancy. So there were none of our participants, actually just one of our participants, who had a relationship and lived together before getting pregnant and having children. None of them have had this sort of discussion beforehand. So they were boyfriend and girlfriend, they had sex, and there was an unplanned pregnancy. And being viewed as this pure woman was important in actually establishing this union, because all of the women that we interviewed told us a variation of this quote that I have here. When I told him I was pregnant, he said, "I know I've been your only man, and I'm sure that this is my child, and therefore I will look after you and we can be a family." So the performance of purity is important in the sense that it will allow the formation of a family. We had one participant who, by her own admission, was liked to party and liked to be out and liked to be in parties and drinking when she was younger, and she had an unplanned pregnancy, and the male did not form a union with her. He left her, and she was a single mother for like 10 years and then had a child with another man who also did not stay with her. So in this idea of performing purity, what the girls that were talking about this, the younger girls that were talking about this, and the older women who had gone through this, they were saying, well, we are not going to say that we want a condom because they're going to think that we are like not naive enough, not pure enough to become the mother of the child, or that they won't trust that we're only having sex with them. So once the men and women are in union, we already have a male and a pregnant woman who have beforehand not really discussed pregnancy at all or discussed contraception at all. And even after pregnancy and after the child has been born, they have this sort of public versus quiet woman persists, in a sense that, again, men will still have sex with different women in their lives. Public women will only use condoms with the public women. So they say condoms only when it's a hookup, and in Spanish they call it choque y fuga. So just one-time thing, not with your partner. And that's how I care for her. And several men said this. I only have one quote here, but they saw themselves as caring for their main women by using condoms with their the others that they have. And women saw the condoms in the wallet, but they didn't use them with them. And we asked also, so if your partner asked you to use a condom, Women said a variation of this. I would think he had unprotected sex with a dirty woman. And we asked men, and men said, if I would think that this woman is being unfaithful to me, or stepping out on me. The discussions of actual contraception occurred only after the first child. And in this discussion, men's influence is very large. So, and one trigger of the discussions of contraception is that when women birth, and most of low-income women in this area birth in the hospital, in the regional hospital, they are urged, encouraged to leave with a contraceptive. So they have this incentive to actually have the discussion of using contraceptions. And like I said, men's perception of their responsibility of taking care of their main woman is experienced by using condoms with the non-main women. And it's also extended into making sure she doesn't have too many children. So several of the men mentioned that they wanted to have not very many children, that wanted to get good education, good nutrition, and good quality of life if you have fewer children. So interestingly, they wanted to have la parejita. They wanted ideally to have one girl and one male child and one girl child. And so they would push, some would say, well, if we only had 2 girls, then I would push for the male child. But their pushing for contraception actually realizes the female use of contraception. They will go to get this injectable, or they will use the pills if the male is on board. Now, male influence is also central to the contraceptive use and contraceptive choice among low-income women because they control the money. They control the access to healthcare. Even though contraceptives are free in the healthcare system, there's a perception that some of them are not good for you. There is an interesting idea that the injectable, which is Depo-Provera, actually causes cancer because it stops the blood, and the bad blood inside women will cause cancer. So every now and then, women will want to see blood, and so stop using the injectable. Male perception of these healthcare system-free contraceptives is poor. They believe they are not as good as the ones that you can get at the shop, at the pharmacy. And so if they are really good, what they want is to have their women use the pharmacy ones. There's also a very large influence of men in reproductive decision-making because they are older. And for younger women, they are living with their parents of this older man. So I need to wrap up here, and I just want to talk a little bit about the perceptions of Zika risk at the time. Most of our interviewees had heard of Zika, but they had not heard of sexual transmission of reproductive implications. They, and even among health professionals, there was a doubt of the link between Zika and severe cognitive impairment, or what we are now calling the Zika cognitive syndrome. So their belief was that it was a fever, it was like dengue, which was something that was promoted with this idea that the same mosquito that dengue and chikungunya has to do with Zika. And so they didn't really think that it had any different implications than dengue or chikungunya. So they expected to have a dengue-like fever and pain symptoms. They expected that it would have no other physical effects other than the ailment itself, maybe death. but they assumed it had a cure. And so this meant that they had no real perception of what possibilities there were for them. So in terms of what this meant and what we sort of discussed with the regional health direction was to make specific Zika messages, not Zika, dengue, and chikungunya altogether, information on how to get contraceptives and free and low cost. And we thought that extending the messages to men and talking about the importance of caring for future offspring would really be listened and could be woven into this sort of idea they have of caring for their main wives. And also target secondary schools and consider the training and health needs of children, of healthcare workers. And I think I'm going to have to leave it there because I may be out of time. I'm going to switch over to Kirsten, if I remember how to do this. Where are you, Kirsten? Okay, I need to find Kirsten first. Here you are. There you go.
All right. Thank you so much, Luthia. Do we want to take a few minutes if there are a few questions for Luthia? Then we could ask a few questions, just a few minutes here, and then we'll move on to our last presenter, Tashir. But we could take a few questions first if anyone wants to ask a question right now. Okay, so instead of opening the mics, which caused some problem before, Luthia, I will just read some of those questions in there, and maybe, can I open up just your mic?
Kristen, can you hear me?
I can hear you.
Okay, perfect. So Luthia should be able to unmute just herself by clicking next to her name.
That would be great. So Luthia, if you can just unmute yourself. One of the first questions we have from Adriana is, can you describe the use of the term public women? Can you hear us, Luthia?
Hey, Kristen, I believe that I can unmute her.
Okay, that would you
so
can.
Let me just go ahead and do that. Yeah.
Okay. So Luthia, while we're trying to work out your microphone, then another question that came up that you can be thinking about. The first one is describing the use of the term public women. And the second one is, can you explain what you mean by performing purity? And maybe I should just pass the presenter role back to you, Luthia, and then when you're done with the questions, you can pass it right on to Sheer.
Yeah, Kristen, I think that that's the best way to do that. So Luthia, once you get the mic, go ahead and mute everyone else if they've been unmuted.
Okay, I think I'm on. Let me see if I can mute everyone else. Oh, it says everybody else is still muted.
Perfect. All right, you are good to go with questions then.
Okay, so both of these questions I can see are related. So what I mean by public women is the ways that men described women that they had sex with was women de la calle, from the streets. And when our assistant who was working with us doing the male interviews, who was a male himself, asked them what they meant, is though they were a mixture of, there was sort of a range going from what the men saw as the most public, which were prostitutes that actually did sex work, to women who they met at casinos and who they met through their work as moto taxi people they flirted with and met at bars, and just a different range of women who lived in different parts of the city that were willing, I guess, to have sex with them. So it was sort of a range. And what they said was that they didn't use condoms with their wives, or what we would assume to be their wives, even though they're not really married, they were in consensual unions. But they used condoms with all the others who were outside of their household. So that's why I'm using the word public. If you have a different word that I could use, that would be great. And the idea of performing purity came about when we were discussing the women that we were talking with sort of had these really constant stories. Women who were 35 and younger and women who were 35 and older all had very similar stories about their how they had sexual experiences before establishing a union, and most had sexual experiences with their boyfriends. Women who were 35 and older had no measure of sexual education in school at all. So their stories were more like, I didn't know anything about sex. I didn't know condoms existed. I didn't know that we could use them. I learned what these things after I got pregnant and I had my child. Women who were 35 and younger had at least some of them some passing information, either through school, through their friends, through outreach from the healthcare systems, because there's a very high teen pregnancy rate in Iquitos. So there's a push to this, to have some more health education in schools. But there's the issue of the Catholic Church. So it's sort of a patchwork, iffy, maybe under the radar. And so what they said, the younger women, was, I had heard about condoms. I knew about condoms, but I couldn't say anything, or I didn't want to say anything because what would he think? Or maybe I mentioned condoms, but he would get angry and say, what, do you think I'm dirty? And so I didn't mention it anymore. And so that's why I meant by this sort of having to perform some sort of naivete. So either say that they didn't know what they knew or hide what they knew because they didn't want to be perceived as being too knowledgeable, because that would sort of mark them as more public and not this quiet girl that you can have a relationship, a long-term relationship and children with. I hope that answers your question. And I see another question. I don't know, Kirsten, if you want me to tackle that or if we want to move on to Cher and just do this at the end. Okay, so the question says, under your perspective, how do you think we could influence men on reproductive contraception use? Is it a matter of Zika risk perception? Yes. I think it is a matter of Zika risk perception. My sense is that once the link between Zika and long-term effects is evident, and people actually told us, oh well, yeah, I'll take care of myself when I see something. So if there's an actual somebody who has a child with microcephaly or who has a child with a disability related to Zika, then people will start really paying a lot of attention. But even before that, I think that in Iquitos, and not only Iquitos, but in a lot of these areas where men sort of hold a very strong opinion on what their sort of main women do, the link to them is the child. And thinking about, and as part of our research, we started asking about what they knew about Zika and how they formed their unions. At the very end of our research, we said, well, this is what we know about Zika, and this is the consequences, and this is how you would prevent it, etc. And we asked both men and women, would you change anything in your day-to-day life? And several men, not all of them, but several said, yes, we would. I would think about getting contraception. I would think about using condoms. I would think about doing this or that. So I think that making it very explicit, the message to men, because right now, because it's a health thing or because it's a pregnancy thing, all the messages, at least until we left Peru, were talking to women, not to men about this. So something that Christine said before, men don't really engage with the healthcare services, and the healthcare services don't engage with men. So I guess it's sort of like a quick question, and I'll pass this on to Sher so we don't go over time. Thank you very much, everybody. And let me find Sher.
Okay. Hi, everyone. I hope everyone can hear me. My presentation is going to be relatively brief because so many of this. My project after Puerto Rico, who is currently in Puerto Rico. We just started collecting our main wave of data. So Dr. Rodriguez Soto was in Puerto Rico over the summer. We collected some preliminary data, so that is what I'll be discussing. So, very briefly, Puerto Rico is a U.S. Commonwealth of the territory. It was acquired by the U.S. in 1898. It's not a full state, and that is important on several levels, primarily for Puerto Rico receiving less in federal funding for healthcare, for things like Medicaid, than the mainland states, and it remains to be seen what the effects will be after Friday with the changes to the healthcare. So there are a lot of question marks with that. But there's also a big medical brain drain with practitioners moving to the West, so doctors are not receiving the same amount of funding for practicing. This will have effects on Zika treatment, and I'll discuss this a bit later. But Puerto Rico is hit pretty hard. So there are over 37,000 cases in Puerto Rico in 2016, also for 4 factors that I will touch on in a few minutes. But research came out of conversations that happened over the spring that I conducted with other colleagues, that we released a public statement talking about why there's a need for increased attention and funding for Zika in Puerto Rico, needing to do with the mode of transmission, primarily with Aedes aegypti, with the mosquito. And the fact that Puerto Rico is essentially, it's a perfect location for Zika to be transmitted because it's warm year-round. There's constant running water due to in old tires and things due to the economy, and there's limited access to clean water and waste management. So Puerto Rico is experienced not only Zika but also other diseases transmitted by the same mosquitoes, so malaria, chikungunya, dengue, and there's a need for informed use of birth control and reproductive and natal care. And the colleagues you just heard have done an excellent job discussing some of the issues with reproductive and natal care in Zika. So there's also a high level of toxic chemicals, which includes Zika in a way.
Here,
yeah.
Cher, I hate to interrupt, but we're having a lot of trouble hearing you correctly. Is there any way that you can either reduce background noise or lean into your mic a little bit more?
Yes. Is this better?
That's much better. Thank you.
Okay. So I will continue like this. Okay. So this working with Dr. Isa Rodriguez Soto. She's currently in Puerto Rico. So this research, the preliminary results that I'm presenting are from when Isa was in Puerto Rico over the summer. She interviewed 90 people on this project. We did an online survey, focus groups, and key informant interviews. She's currently collecting more data to add on to this, so I won't be presenting quite as much data. But one of the issues we're finding with Puerto Rico is that it's currently experiencing a pretty big economic crisis. It's an external debt in the trillions. And what that's meant is that there's been massive migration to the mainland. So there are currently more Puerto Ricans on the mainland United States, about 4 million, than there are in Puerto Rico, about 3.5 million. And what that's meant is that the things have been left unattended, and there have been standing bodies of water that just haven't been cleaned. Like this, due to the economy, there's been limited funding for things like waste management. That's been a breeding ground for mosquitoes. Mm. There's also been a lot of controversy over the CDC spraying of Naled, which is an insecticide. In Puerto Rico, it's unapproved by the Puerto Rican government or by the people. And the CDC officials from the U.S. insisted that it be used. And as far as President Obama, who recorded a video urging Puerto Ricans to follow the CDC recommendations. And so objections to aerial spraying of Naled has been both from the lack of approval from Puerto Ricans and due to the possible effects on pregnant women. So other preliminary results, there's already a lot of distrust of Puerto Rican and U.S. government agencies and the government in general, that agencies have not been reporting sufficient information to communities about what's going on with Zika and what can be done to protect against it. So especially a lot of the distrust right now is aimed at the CDC. As I said, vigorous opposition to CDC's aerial spraying of Naled, and it's gone to the point where the CDC employees are no longer wearing badges with the CDC logo due to opposition. So they're afraid to be identified as working with the CDC. And a lot of the objections are seen as Puerto Rico being seen as a laboratory, as an experiment to see what happens without any valid evidence. And so most of the research we found, most of the data has been centered on lack of trust of the government, also because there's a lack of concern about Zika itself. As I said, Puerto Rico has a long experience with other mosquito-borne diseases, so dengue, chikungunya, malaria. People have experience with these diseases, so they're not overly concerned about Zika itself. Most of the people concerned are pregnant women or women who are trying to become pregnant, but they're not taking additional precautions to protect against Zika. So it's seen as a long list of problems that are happening right now. Also, Guillain-Barré, it's a neurological disorder. Its relationship, there's been a lot of attention on Guillain-Barré, but its relationship with Zika and its consequences are not clear to people. So people don't understand it, so they're not overly concerned about it. There's also an issue with vectorship, that because people have had experience with other mosquito-borne diseases, people understand that aspect of Zika. They understand protecting against the mosquito. But the sexual transmission aspect of Zika is novel. I think there's a little bit less understanding about that aspect of Zika, especially for women who are already pregnant. They don't see a need to wear a condom because the primary use of a condom is to protect against pregnancy, but if they're already pregnant, then they don't see the need for a condom. They're not thinking about contracting the virus through sex. One of the biggest issues right now focuses on structural factors. Puerto Rico currently experiencing high levels of unemployment, I think about 13–14%. So people are moving from rural areas to the cities for work. So the bigger cities like San Juan are experiencing overcrowding. What that's meant is that cities like San Juan are there are feeding grounds for mosquitoes and for standing water. But because of the economy, things aren't being cleaned up. And also because of the weather, The weather encourages the mosquitoes year-round. In the low 80s, it's humid, it's a tropical environment, so the mosquitoes are year-round. It's not like in the mainland where they die down during the winter. But some of the protections against the mosquito, like window and screen doors, are luxury for people in low and middle socio-economic groups, which is much of the island. Poverty is around 47%. A lot of people can't afford it. The government now is trying to provide screen doors for households with pregnant women, but that doesn't cover everyone. Much of the population needs some sort of protection, but not everyone is being helped. And as I said, the medical brain drain, a lot of the doctors in Puerto Rico are moving to the mainland. And what that's meant is there's a delayed identification of Zika. There aren't enough doctors who can identify Zika in patients. And especially since Zika is asymptomatic, people with Zika don't always know that they have it, so they don't always think to make an appointment. And a lot of women only see that they have Zika when they go for prenatal care. So, and by the time a lot of people think that it's tested for, it's too late. What we're doing right now, so the first child with Zika-associated microcephaly was born in October, so 3 months ago, and that really put a face to the epidemic. That the family of the child went public because they were referred to a pediatric neurologist and could not get an appointment for months. This goes back to my point about the medical brain drain, that by the time they were able to see someone, it's too late. There aren't enough specialists to help the population. And there's a lack of funding for healthcare. It said it remains to be seen what will happen with funding for healthcare under the new government administration. And we're currently right now looking also at pandemics. Pandemics looking at multiple health conditions with structural factors. So we're looking also at Zika's relationships with other infectious diseases, microcephaly, Guillain-Barré, dengue. Puerto Rico had an influenza epidemic beginning of last year. So we're looking right now at its relationships with other diseases. So that's now. I know it's a bit shorter, but our research is still relatively preliminary. So that's what I have right now. The pass is to Kristen. I can go from there.
All right, thank you, Cher. Is there any questions that they would like to ask specifically to Cher? We can take a few minutes, and if I see some questions, I'll go ahead and just pass. So, Adriana, do you want to go ahead and just type the questions? If people have questions, go ahead and type them right in the chat window. And Cher, I'm going to go ahead and pass the presenter role back to you, so you can go ahead and take a few questions and answer those.
Okay. Okay, so I'm going to answer Adriana. So we're collecting data on accessing the free birth control that the CDC has offered. That's one of the questions we're asking. I know that it is hard to access, and I know that there's been responses. They've been handing out kits. The CDC has been handing out kits to people, but there's been some confusion because each kit has, I think, 22 condoms, and it seems like a random amount for people. People don't know why that number specifically. So it's a conversation we're still having with people. So it's a good question, and we are collecting data. Let's see. It's a good question also of why sexual transmission has not been a priority. I think for Puerto Rico, at least because people haven't seen it as a priority, maybe that's another one of the things another one of the questions we're asking right now. But I know we have a few questions we haven't been able to answer yet. That's because we're still asking them right now. But it hasn't been a priority for the people who have been accessing it either, the treatment. So, let's see. And to answer Vicky, at least in Puerto Rico, I would not be surprised. She asked if it can take up to a month to get lab work back. I would say that I would not be surprised if that were true, mainly due to the brain drain. That there have been so many people moving to the U.S. that it takes everyone a long time to get anything back, medically speaking. Not only appointments, but lab results and just about anything else. So, and abortions as well. There are abortion clinics for women who have been told that they have Zika and they're pregnant. Abortion is legal in Puerto Rico, but it's expensive. So it's not really accessible. So
here we also have a question from Holly.
Let's see.
It's a little further up in the thread.
Okay. To answer, Holly asked about the discussion about religion and protection in our research. We've seen a bit of that as well. That's a conversation that people are having as well. That we're seeing whether that's a topic that comes up in our research now. That Isa is she's in Puerto Rico now, about to start conducting more interviews. So it'd be interesting to see if that topic comes up as much to us as it does, as much as you have. But it's tentatively yes. So there's quite a good conversation going on. I'm sorting through some of the questions in the chat box. So I'm sorry for the delay. So to follow up on Isa, we're following up on actually follow up with the religious discourse. So what people say and what people do are two different questions. So to answer Vicky, she asked why only 2 babies. So Isa's answering Vicky's question right now. So part of it has to do with abortion access. So Kristen, I'm going to transfer this back to you again.
All right, thank you so much, Sheer. Can everybody hear me all right? Okay, so I'd like to thank each of our presenters. Each one of your presentations was really incredible, presenting incredible research and preliminary findings that it's going to be exciting to watch as it progresses. I think they each gave some great detailed ethnographic descriptions of specific community responses to risk, and then also particularly to prevention messages that are out there, and possibly suggestions and recommendations for how we can improve those. I wanted, before I open up to further questions, just to explain a little bit more about our group for anybody new. We are the Society of Medical Anthropology Zika TIG group. TIG actually is an acronym standing for Temporary Interest Group. And the idea behind developing a TIG was that the Society of Medical Anthropology wanted to have a rapid response mechanism for people to be able to quickly respond to emergencies that happened, or quickly be able to respond to health issues out there. We are the first one of this mechanism, and we have been very successful in the last almost year now. We really started last February. And this has been such a great success, as Juliet was able to highlight some of our successes, has really been just crowdsourcing and networking among anthropologists, but then also outside of academia. And I think even here on our call today, we have over 12 different agencies represented. And I think that's a great success, showing that we really can work quickly among each other and network well to get a rapid response to health emergencies happening. Now, the idea was that the TIGs would be temporary, and so that does lead people to question what we are going to do in the future. And I just saw a question from Susan. Yes, if you want to join the Zika group right now, the best way to join our group is by our Facebook page. And you should be able to see the link right there. I don't think you can click on it since it's in slideshow format, but there's the link to our Facebook page, and that's the easiest way to join our group. And that's the easiest way we've been able to network with each other. One other thing that we put together, thanks to Dion, who I think she's on the call over the summer, was, and there she was mentioning it right now. So Dio's just getting to that. Thanks to Dion Claiborne, she put together a survey over the summer. And this was our research assessment survey. This was our idea of, it's a quick 5-minute survey, but it gives us an idea of who is doing what out there in terms of research related to Zika. And it's been a great tool for being able to network and connect people together. And so our Facebook link is there, and the link to the survey is there. If you haven't already taken it, it only takes a few minutes of your time and can help you figure out who else might be researching in the area or who might be looking at some of the same issues. We'll have both of those links later on. AAAs can have that posted. This whole webinar is being recorded and will be available for view later on after this webinar, and we'll have those links available also. And Juliet added in, the survey has been really helpful, so please do fill it in if you haven't already done it. So moving forward, while we are a temporary interest group, we are wanting to decide the next steps. And really what we are working towards, what we're moving towards, is we'd like to broaden our umbrella a bit to focus on public health emergencies at the broader level and become more of a permanent special interest group of the Society of Medical Anthropology. And then possibly having multiple Zika groups underneath that would focus on one particular. It could be the Zika group underneath, and then possibly next of an emerging emergency is yellow fever, and having a yellow fever specific interest group under this larger umbrella. So that's what we are working with the Society of Medical Anthropology and along with the AAAs. And we'll keep all of our colleagues up to date on the process and how the structure and the timeline and how that's going to move forward. And if anybody is interested in being more involved in kind of the steering committee of setting up this group, please feel free to email me or post a message on Facebook, get a hold of us some way. And so what we wanted to do in this, okay, and so Juliet's also put the link to the survey directly in our chat window, so you can click on the link right there. What we wanted to spend the last 25 minutes or so, let's see, I'm just checking out. And what we wanted to do for the last 25 minutes is just open it up to question and answers. If it might be, sounds like every time we've tried to unmute everyone, then it's gotten a little complicated and hard for everybody to hear. So we will probably just keep it on mute, and I would be fine with facilitating this question and answer discussion. Hopefully I can just pass the mic to one of our presenters or pass the presenter role to somebody to try to give an answer. So I will kind of launch some questions off, and if any, and this is not just to our presenters too. We know we have a lot of different people on the line today with some great expertise, and we would like to give people a chance to share their thoughts and share their expertise and answer to any of these questions. So if you just put in the chat window that you would like to give an answer to that, I'll go ahead and just pass the presenter role over to you. So to start us out, I see some of the broader discussions is kind of looking at sexual transmission, and this is definitely one of the ways that this emergency has responded differently than other mosquito-borne emergencies in the past. So one of the questions is kind of looking at why this hasn't really been a priority. Is it just because of political sensitivity, or are there other reasons? So I will just kind of post this first question out there, and if anybody who wants to kind of respond to that could kind of let me know, and I can kind of I'll just pass the presenter role over to you. All right, so I'm going to pass this over to Lucia, and she's going to respond to that.
I just want to mention something that I think is what happened in Peru, and this is sort of like from my Peruvian experience, is that the first response to a mosquito-borne virus is always the area of mosquito-borne diseases or the area of zoonosis. So, and in the Peruvian healthcare system at least, and I think that this is probably replicated across other healthcare systems in Latin America, these areas are very much siloed. So the mosquito-borne people are this kind of people, the reproductive health people are this kind of people. And so they have each their own sort of ways to go forward. And there's not a lot of coordination across these sort of silos within the healthcare system at all levels. So I would say that from the actual decision-making level in Lima or at the regional health directions and right down to the other smaller healthcare systems. So when we talked to the healthcare providers and we went to the Moronococha Healthcare Center, the first person they had us talk to, because we mentioned Zika and mosquitoes, was the biologist, which was great. We had get some really good information talking with the biologist. But when he found out we were interested in contraception, he's like, oh, you want to talk to the I was done.
Sorry, Lucia, I think I had a slip of my mouth there and I accidentally cut you off. Sorry about that.
Okay, so I think I'm done with my answer. It's sort of like the idea of the silos and not really connecting across different groups. So do you want me to pass it on to Kristen again?
Yeah, let's go ahead and pass it back to Kristen, who will moderate the rest of the questions.
All right, thank you so much, Lucia, for that. And I'll throw out one of another questions that this kind of relates directly to what you started to speak on, but also talking about discussing just some of the tensions there's been, kind of working with national governments, working across governments and across countries, particularly the U.S. and regarding with Puerto Rico. Shear's presentation really showed some of that conflict that's out there. So I don't know if Shear or even I think Adriana, you're on the line too. I don't know if either one of you would like to try to discuss some of the tension of working with national governments. Or anyone else who, okay, so Adriana, the issue was just bringing up some of the tension of working with national governments, working across different governments from across different agencies and some of that tension that's out there. Would you like to try to discuss some of that? Okay, I'm going to pass this over to you then. Oh, I don't see you in the, oh, this is alphabetical, but I'm not seeing you in here as a choice to pass over to. Do you have, Laurel, do you know why Adriana, she's showing up in our chat window, but she's not showing up in my list of passing presenter roles?
I suspect because she is logged in through the browser, where you need to be logged in as a, to take the presenter role, you need to be on the desktop app, yeah.
Adriana, do you want to try to work on typing anything in the window that I can then also translate verbally? And if there's anyone else who'd like to maybe think of that. There was a follow-up question while we're focused on Puerto Rico too. There's a follow-up question from Lisa to just wanting to clarify on the low rates of microcephaly that's been found in Puerto Rico, that's related to abortion access that is there. And is that correct? Is she understanding that correctly? So Shira, I don't know if you want to elaborate more, or even Isa, I think she's on here, if I can pass it to her too, if she would like to elaborate. So Adriana's response, though, the major issue in Puerto Rico is the lack of funds for public health. All right, I'm going to pass the presenter role to Isa. So Isa, you just have to accept that there's a little window that will pop up that says they would like to pass you the presenter role, and you just have to accept that. So are you there? Not sure it worked.
Kristen, we could try unmuting everybody.
Okay, should we try that?
Yeah, and just hoping that we don't have major feedback issues. So if I could have all the participants who are not answering a question, just try to reduce any background noise, no mouth breathing, and maybe we can make out what Isa's answer is.
Okay, that sounds good.
Hello, can you hear me?
Yes, we can.
Okay, good. So what I would say to Lisa's question is, I think it's a combination of things. So first off, the epidemic in Puerto Rico started later. And so, for example, come January last year, people were thinking that we were going to see the first cases of microcephaly in October, as was the case. And part of it will be, we'll probably see more of those cases, unfortunately, in the coming months, just because of timing with pregnancy and when the epidemic started. And then the other part of abortion being legal, I think a lot of Latin American countries get portrayed as highly religious, and they are, but there's also this sort of dissonance between how people think and believe and what they actually do. And so abortion is legal, it is safe, it's costly if it's going to a private clinic, which most of them are. But people, we found, at least from our survey, that people would consider, even though they have marked their highly religious and different religious affiliations, they would still consider abortion if they had any sort of test done that would indicate some disorder or some issues with their fetus. And so I think it's going to be, at least in the case of Puerto Rico, a combination of factors. There's always obviously the cases of people that are highly religious and would never consider abortion. And so there's sort of, it runs the gamut in that sense. I hope that answers some of that.
Yes, great. Thank you so much, Isa.
You're welcome.
All right, so we only have 15 minutes left, so I just want to make sure we touch on a few other questions that are in there. I'm trying to quickly kind of make sure we get down the list. So Ida has a question.
Oh, hi, sorry, this is Adriana. I just wanted to add one thing to Isa's answer, which is that there are rumors among community organizers of large numbers of abortions, but it's very much just at the level of rumors.
Oh, thank you for adding that, Adriana. Okay, so one of the next questions is actually from Ida regarding looking at media, and this is kind of just out to everyone, given that our work has been about rapid response and wanting to quickly get preliminary findings and quickly get information out there and working with the evolving science. Has there been considerations proactively working with local media? I don't know if anyone wants to speak to working with local media. So the question was just working proactively with local media about the evolving science and a rapid response. Okay, well, while that question's out there and people may be thinking about that, and feel free to just speak up. Speak up if you come back to that. Let's see, I think Christine, go ahead, Christine. Everybody should be unmuted. Can you hear me, Christine?
I can hear you. Can you hear me?
Yes, go ahead.
Great. So this is not directly related to working to local media, but just some things, thinking about the media more generally and rapid response when information is still evolving. There's a lot of discussion about how, in the context of when we are still learning the science, understanding the consequences of something, how to present that in the media. So for example, in the beginning stages of the epidemic, when there was still a lot of back and forth about what was actually causing the increase in cases of microcephaly, about how Zika could be transmitted or not, having all of that presented in the media in live time, in many ways ended up being very confusing, very overwhelming. And we spoke to several individuals who ended up just kind of shutting down in terms of how, in terms of intaking that information. So it really made us think about, how do you deal with media messaging? How do you do campaign? How do you balance making sure that individuals, communities are keeping, are updated and kind of the most cutting edge information, but when that information is evolving, changing on a day-to-day basis, how you do that in a way that you don't turn people off, that you don't overwhelm them. So that was something that really came up in terms of that balance, in terms of making sure people are informed, but also making sure that they're not overwhelmed by inconsistent and different messages and just many doubts.
All right, great. Thank you so much, Christine. So we want to move on to another question. Alfonso has a question about the integration, and was the integration of Zika into arboviruses, was that a right approach to address the epidemic? Did this integration kind of ignore other sources of transmission? And I think I heard Jorge is on and can maybe speak to that.
Yeah, hello, good morning, everyone. So as you know, arbovirus is not really a biological classification. It stands for arthropod-borne virus. And when the Zika epidemic started, it was only known to be transmitted by mosquitoes. So it was there was no way for them to not classify it as an arbovirus. And still today, it's still the main form of transmission is by mosquito. But yeah, with what we know now, I think we should probably create a new classification for it, because we're not used to viruses being transmitted both by an arthropod and be sexually transmitted. But at the moment, because it was not until the epidemic was ongoing that we started learning that it could be sexually transmitted. Having known that, probably would have been better to classify it in a different way. I imagine it also has to do with the way that resources are allocated. And as was mentioned before, because a lot of this is siloed, so there are resources for fighting mosquito-borne diseases and there are resources for fighting sexually transmitted diseases, and most countries have those resources separated, not only the people, but the money that goes towards them. So by putting it in the arbovirus group, it was probably the way that they could mobilize all that money and resources. But even still now, if we could rename it or reclassify it, maybe it would sort of reorganize the way that management of it's carried out. But I think it has to do mostly with the fact that at first we thought it was only an arbovirus, as the other flavivirus, the other members of that family, like yellow fever, dengue, and chikungunya, they're all arboviruses.
Great, thank you so much, Rafael. Another question out there, or I'm sorry, thank you so much, Jorge. I was looking at the next question. Thank you, Jorge, very much. Another question from Rafael: has anyone done research on the impact of rumors of pesticides causing microcephaly rather than Zika? I don't know if anybody's done research or at least heard some testimonials in the field about the rumors of pesticides being the ones that are causing microcephaly. And anyone who wants to speak to that could go ahead and speak to that.
Well, maybe I can elaborate on my question. Can you hear me?
Yes, go ahead. And tell it.
Okay.
State your name again so everybody is together.
So I'm Raphael Raban, medical anthropologist working in French Caribbean island of Guadeloupe. And what I observed during the start of the outbreak, and when there wasn't yet a lot of scientific research backing up the causes of microcephaly, was that a lot of Guadeloupeans really emphasized the causation as potential, like as being pesticides rather than the Zika virus itself, and that was wrapped into a relationship to mistrust of state power and public health. And I don't know if that's specific to Guadeloupe, where there's really this dimension of mistrust of the state and the circulation of rumors are important, or if that was the case in other places as well.
Oh, great. Thank you for bringing this up. So has anybody else seen similar responses in other areas of the mistrust of the information?
Yeah, just anecdotally, the information that suggested, or the sort of comments online and articles and things like that that suggested that pesticide use in Brazil led to the microcephaly widely circulated in Puerto Rico and are often cited in casual conversations that I've had with friends, with family, with just acquaintances. People are well aware of that theory, and it seems very plausible to people. So that seems a very common comment to hear about in Puerto Rico.
Yeah, and I would add to that as well. In Puerto Rico, that mistrust with the government, with federal level and local level, and it sort of ties back to what we were saying, or they were talking about with the media. And so the CDC officials that we managed to interview had a lot of issues with the fact that they would have to put out information that would change, and that increased the mistrust, right, of this information and of those agencies as well.
If I could add something, in addition to the mistrust, I think related to that, the mention of the pesticides, I think that even in our case, health providers that we talked to both on the record and off the record were not convinced of the link between microcephaly and Zika. And so we could also do a much better job, I think, of actually communicating with the people who have to communicate with the public health messages.
Yes, thank you for adding that. That's an important distinction, too, of even the healthcare providers and where their beliefs are and accepting messages. Jorge actually had brought up, so Jorge, are you still on the line? He had brought up, great, I wanted to mention his comment here, and then maybe he wants to elaborate a little bit, but also thinking of the risk of focusing on microcephaly as the only sign of child harm. There is pathological evidence that it's probably a Zika spectrum of neurological and developmental issues that might not show up until later in a child's life.
Yeah. So what we know is that the mosquito does have a predilection for neurons and neural tissue, especially the one that is developing. And depending on where during the development of the baby the mom gets infected, there might be different amounts of the virus that goes into the baby's developing nervous system. The pathologists that have published widely, mostly in pathology journals or medical journals, they talk about other issues that are probably going to start appearing, learning impediments, ADHD, symptoms similar to the autism spectrum disorder, because we don't know, depending on the area of the brain where the virus latches on. So what we see, and it's important for us as anthropologists as well, to start thinking in the future, that it's going to be, this might go beyond the families with microcephalic babies, which are of course the I guess the most dramatic of all the outcomes. But there are going to be a lot of other outcomes that we're going to have to see in terms of kids with learning or neurodevelopmental disabilities that are going to have to be managed, especially in developing nations in Latin America.
Yes. Yeah, definitely think it's a broader range than just thinking of only the microcephaly right then. Thank you, Jorge, for bringing that up. And then is Meg Stallup still on the line?
If not, may I make one more comment about
Yes.
what was just being discussed? This is Adriana, and I think that was Jorge that was speaking just now.
Yes, it was.
So I agree with Jorge that there's a lot of cause for concern about the spectrum of disorders that are starting to be seen in young infants. And one of the problems or the concerns that I have in Puerto Rico is that as we go further and further into austerity measures and the population of health professionals declines further on the island, we're going to also confront the reality that it is children with disabilities that are seeing the first effects of those austerity policies. So if we have a large cohort of infants that need either treatments or therapy or ongoing habilitation or stimulation of a particular sort, we're going to have very few people with the capacity to deliver those professional services and almost no public funding for people to access that who do not have private insurance. So I think this is a real concern in terms of addressing precisely that neurological diversity that Jorge was just talking about.
Great, thank you, Adriana. So we are just about out of time. Laurel, can I ask a quick question? Will there be a way to get a copy of the transcript from our chat window? Can we copy that in?
Let me look into that. There should be a way to export that.
Okay. So, and we can get a list of the participants who logged on today too?
And that we can export, yes.
Okay, so I know a few people have asked for copies of the slides, and people, I think there's some wonderful ideas that were brought up in the discussion. Not all of them were we able to actually verbally talk about, but they're in the chat window. So we will try to get a list of all of those questions in there and try to also get a summary notes to be passed along to everyone who was here today. So I appreciate everybody taking the time today and spending some time with us this morning, hearing about these preliminary findings and adding your ideas and thoughts of ways moving forward in the future. Please stay in touch. If you're not already on our Facebook group page, please join that and take the research assessment survey if you haven't already taken that. And if there's any questions in the future, feel free to email me and I will at least get you in touch with whoever you need to. And we'll try to share contact information and some notes after today too.
And Kristen, if you can pass the presenter role back to me, I have a slide ready with some further information on where folks can find the webinar and the files.
Great. So I have passed it to you.
Excellent. So you can look for the transcripts of the chat box and the presentations, as well as the recording of this webinar. They will all be available on our website at americananswer.org/webinars. If you have any questions or comments, feel free to send me an email. I will leave this up for a minute. And without further ado, Kristen, I guess that's the end of the show.
All right. Thank you, everyone.
Thanks. Bye.